Yeah, this is my third case. So, a 40-year-old female was diagnosed in 2022, the last year, so May 2022, with CML-CP. She was started on dasatinib 100 mg once daily. So, after 3 months of treatment, she attended CHR. But soon after 1 month, she complained of headache, for which the CSF analysis was done, and the CSF flow cytometry was suggestive of lymphoid blastocysts. So, for which she received high-dose methotrexate 4 cycles along with dasatinib, and the CSF malignant cytology was negative. She was consolidated with whole brain RT. So her peripheral blood BCR-ABL was 91% at the point of time, and hemogram showed presence of blast, for which TKD mutation analysis was done. So post 4 cycles of high-dose methotrexate and dasatinib, so her peripheral blood BCR-ABL was 91%, and hemogram showed blast, and for which TKD mutation analysis was done. And the TKD mutation analysis showed V299L and F317I mutations, for which received a lymphoid type of induction with GMAL protocol and along with ponatinib. So post-induction, she achieved remission with this chemotherapy and ponatinib combination, and the MRD was negative. In January, so of this year, HLA typing was done, which showed that she had a 12/12 match. She was consulted for allogeneic stem cell transplantation, and in view of cost constraints, the ponatinib was discontinued for some period of time and was changed to nilotinib. And while the bridging for the transplant, so she consented for the transplant, and an allogeneic stem cell transplantation was done with site EBA conditioning. And the day 100 chimerism was 99%, and she is fine as of day 160 post-transplant. So in this case, is there any other better way of managing this case? So you have seen that the patient had a initially CP attained CHR, but soon after 1 to 2 months, she had a CSF positive for the lymphoid blast, for which she received high-dose methotrexate, and had a relapse in the bone marrow with BCR-ABL of 91% and blast, for which she received GMAL with ponatinib and has a dual compound mutations, for which she attained remission and underwent a full matched sibling allogeneic transplant. And she is doing, as of now, day 160. The immunosuppression was tampered, and she is doing fine. So is there any other better way of managing this case? And does this patient needs TK now? If at all we need to start the TK, what would be the better? We need to go back to the ponatinib, or is nilotinib fine? If at all she needs maintenance chemotherapy, so what is the better maintenance TK in this case?
Yeah, I think this patient was managed very well. The question, I suppose, I just said I'm not one who does bone marrows necessarily a diagnosis, but had you done a bone marrow, whether you would have found any hint of lymphoid malignancy at the time of diagnosis, because 4 months later she had frank ALL. The questions that I would address, you mentioned that she received GM-ALL, that's an intensive chemotherapy regimen, along with ponatinib. It was a randomized trial that was conducted comparing ponatinib versus imatinib using a gentler regimen. In fact, the induction was vincristine and prednisone alone. And the response rate, that is MRD negative, was the definition of response, it was about double with ponatinib. So there's no question that the more potent TKI will produce a higher response than with imatinib. And obviously the mutations could also drive you to ponatinib as well. There have also been studies from Italy using gentle chemotherapy in combination with blinatumomab. So the patient was managed very well and is doing very well. And the question, there are two questions that are being raised. No one knows what the best therapy is for lymphoid blast crisis or for de novo Philadelphia positive ALL, but it's pretty clear that second or third generation TKI is preferable. The response rates are extremely high, and there have been a number of studies done in pediatrics which show cure without the need of an allogeneic transplant. So it's my understanding that the pediatricians don't immediately default to allogeneic transplants in people who have done extremely well molecularly. And that's also true of adults, although there's less organized data in that regard. But we still refer them all for allogeneic transplant, although I'm not certain it's necessary in all of them. The question about maintenance TKI was addressed in the previous patient, and I would recommend it, and probably use ponatinib at the dose of 15 milligrams. But this is a nice case to end on compared to the others, since she has done so well with good management.
I suppose one concern I would have would be long-term toxicity with the whole brain radiotherapy followed by the Cy-TBI transplant. So I might have taken a non-TBI approach for the transplant. But I completely agree that transplant was the right option for this patient. In terms of the TKI, the mutations that she has, the V299L and the FT179, should both be sensitive to nilotinib. But again, it's potentially a compound mutation, so may have less sensitivity to both nilotinib and ponatinib. Ponatinib has much better CNS penetration than nilotinib, so if it was available, I would say ponatinib for the TKI maintenance post-transplant, and I would say probably this patient does need it because she's had CNS disease. The other argument would be because she's had whole brain radiotherapy and cyclic TBI, she might have quite a leaky blood-brain barrier, so actually the nilotinib might cross the blood-brain barrier a bit better for her. And I guess if you were giving reduced intensity transplant, what we do, or what we did with the UK studies in the patients that got reduced intensity, was they got 3 monthly intrathecal methotrexate for 2 years post-transplant to try and minimize recurrence. I would completely agree with Charlie that I think in the next 5 years, a lot of these patients will not be getting transplanted. They will be getting essentially a chemo-free approach with a TKI and immunotherapy, and probably won't need to go to transplant.
I sometimes feel that because of the patent law, Professor Malhotra has already warned what is the cost of asciminib going to be in India. Transplant might work out to be cheaper for many patients in India. I don't know whether my assumption is correct. I know they do require post-transplant, but without the transplant also, they're anyway going to require the TKI. So, but the sustainability for a government program can be very difficult unless you justify the cost of the latest generation drug into a treatment plan. So the whole cost of the entire state will go towards the drug alone.
Can I just, we're talking about cost. The cost of the regular dose of asciminib in the United States is $224,000. If you use the higher dose for the T315I, I have a slide here that says it's greater than $2 million a year. I don't know if that's right, but it's somewhere in between. And taking it for a long, long time. I don't know what they plan to charge when it's introduced in India.